Thank you very much for the invitation today to speak to you all. Quite rightly, I'm Dr. Jack Barrett. I'm a Paramedic Senior Research Fellow with South East Coast Ambulance Service and also Air Ambulance Charity, Kent, Surrey, Sussex. And my research has predominantly focused on head injuries and traumatic brain injuries. And through the two organisations, I can span both the mild presentations that we see in the ambulance service and the critical care presentations and the severe head injuries we see in the air ambulance. Today I'm going to talk to you about my research in the mild head injury presentations. That's predominantly in older adults who fall from standing height are one of the leading causes of major trauma and traumatic brain injuries. And this very much stemmed from my clinical practice. So I can almost guarantee every shift I did on a truck, my first patient was usually an older adult who had fallen over. And 90% of these patients would not have an injury or have a very mild injury of some sort. But if they hit their head, and especially if they're taking an anticoagulant medication, so a blood thinning medication, you can almost guarantee that my crewmate would say, "You're going to hospital," and there'd be no discussion about it, because there was a real concern that that patient might have a bleed in their head. And I'd be standing there sort of newly qualified thinking, well, why? So I had the opportunity through our research and development department to explore this in a little bit more detail. And the first way I went about doing that was just going to registries. So the Trauma Audit and Research Network, or TARN, which is now going through a bit of a revision, they collect data on all major traumas that go to major trauma centres across the UK. And I specifically looked at patients that presented with a head injury or a traumatic brain injury in our region, so across Kent, Surrey and Sussex. And what I saw there was actually most of these patients present with mild symptoms, so a Glasgow Coma Score scale score of 13 to 15, so what we call a mild head injury. But when these patients then had a scan, they were found to have quite significant brain injuries. And most of these patients were going to trauma units or emergency departments where neurosurgery wasn't on site. So that then led me to think, well, is there a way we can improve the service we give to these patients? And so through support from the Clinical Doctoral Research Fellowship, through the NIHR, I managed to do my PhD, which first undertook a systematic literature review to see whether or not we can identify the symptoms on scene, to identify patients that might be eligible for neurosurgical intervention or even have signs of a traumatic brain injury. That was not particularly fruitful, I would say. I didn't get very much from the literature, but just to identify that there's quite a bit of bias towards older adults. So the guidelines are very risk adverse, but equally, as soon as you sort of hit the age of 70, you're less likely to get a neurosurgical intervention because there's a self-fulfilling prophecy that these adults won't have a good outcome. So I then looked at our hospitals in Sussex and Kent, got records for about just over 2,000 patients, well, 3,000 patients, closer to 3,000 patients who were seen by CCAM in a one-year period, and looked at who we took to hospital and then which of those patients had a bleed. Most of those patients that we did take to hospital, we took most patients to hospital, and most patients we did take to hospital didn't have a pathology on their heads, so they didn't present with a bleed. And I looked at the reasons why we were taking them to the hospital, and it was usually due to the fact they're on a blood thinning medication, but that wasn't necessarily associated with a bleed, and other factors that I couldn't quite measure. So we weren't very good at measuring clinical frailty scores, and we weren't very good at measuring ethnicity if you're a non-white. So there were things missing in the data that couldn't quite explain it, but there was enough data or enough evidence to suggest some of the reasons why a patient may not have a bleed. And so through the outputs of that work, I was then able to work with our National Ambulance clinical guidelines, discuss with that party as to what changes in the guidelines need to be made. And one of the key changes we made is actually recognising that older adults are a group of patients in their own right, and we shouldn't be clumping adults all as one. However, one thing I missed out when designing my PhD was actually getting the views of the clinicians that are seeing these patients. So I had all this quantitative data, but I didn't actually understand the why. Why was this happening? So through the College of Paramedics, so our professional body, I was able to apply for a small bit of money and do a national survey and interview paramedics, ambulance technicians, emergency care support workers, and understand the decision-making processes that they go through. And it was very much risk adverse. They were very worried about missing a bleed in these patients. But they also understood that most of these patients wouldn't have a bleed, and that going to the emergency department is very risky for these patients. And this is in recent years as well, off the back of COVID and all the pressures that we're seeing in our emergency departments. The problem they had is that our clinical guidelines were very prescriptive. They weren't so much guidelines as they were directives. And they really struggled to do what was best for the patient and what was best for the service and for their own sort of what they would call sort of protection. So that, again, really helped us inform the clinical guidelines and allowed us to make an argument for the case of just giving our paramedics and our crews just a bit more breathing room when assessing these frail older adults. And then off the back of that, I then thought, well, what's next? So I've done my PhD. I'm now applying for some money from the Research for Patient Benefit grant. So we've been shortlisted for stage 2, and I'm not sleeping very much at the moment while I finish that stage 2 application. But we want to look at patients who don't present with any classic head injury symptoms, but they are taking blood thinning medication. Because our guidelines say that regardless of symptoms, these patients need to go to the emergency department. But the level of evidence to support this practice is opinion-based. So there's not sufficient evidence to really sort of support that guideline. So we want to do a prospective piece of work that's actually going to try and assess the risks in these patients. And then where we go from there, who knows? But hopefully we'll get some funding for it. Anyway, thank you very much for the time. Talk's been really interesting. And these sessions always remind me I need to get much better at designing posters because it is a skill. So thank you very much.
Thanks, Jeff. So thank you. It's really impressive in terms of the impact, in terms of clinical guidelines and the next step. So good luck with your stage 2 for RFQB. But one of the things that struck us looking at the poster is that you put together a really impressive team of collaborators here. So the question is, how did you engage with others to build that team? And if you can tell us briefly what the different members of the team, perhaps not going through everybody, what they brought to the project. So
the first bit, so it's networking. So it's speaking to finding very good supervisors, finding out who their network is, and asking to be introduced to people that can either get you in front of clinical academics, clinicians, and academics. There's 3 groups there that can help you get a better understanding of the wider system. So as I said, I'm a paramedic, so I only see the world through an ambulance and one patient at a time. I was I just didn't know what was going on in the wider health service. So getting exposure to different professionals all throughout the patient care pathway to understand what the patient was going through. And then building that research capacity, it's finding the people that is going to allow you to do the research in different trusts. So those are the research departments. Information governance, data sharing agreements, getting a hold of those people that's going to allow you access to data and sharing it between organisations. It's a real challenge, and that's what I spent most of my PhD doing, is getting permissions to do that. And then finding people who have an interest in this area or have the capability to support and progress your research. And you've got to find out what motivates them. So is it the subjects of interest to them? Are they looking to get a name on a paper to increase their research profile? Do they just want accruals for their trust, so on portfolio accruals? And understanding what it is and then negotiating those terms to get them on board. And if you understand what motivates them, you'll make life a lot easier for yourself.
I think what we're all really envious around is how you've managed to put together a programme of work along this topic. So a comprehensive programme of research, so you did preliminary work, you've analysed routinely collected data, you've done some qualitative work. So again, you know, building that profile and that sort of that programme of work in your subject. So what would be your top tips for other researchers in the room about how you look to develop a programme of research rather than an individual study?
Yes, thank you. So I never set out to do all of this. So that's the first thing. That's the thing. Never set out to do it, and start small. And if you think it's small, go smaller. Because from the beginning, I was only one person. I was quite limited in my knowledge and expertise. So I started in a very sort of small sandbox, and just doing a little bit of work. As I said in my last answer, it just opens up opportunities and conversations with other people. And then as your network grows, and you get a bit more time in your work plan, if you're lucky to do that, or you find money to buy yourself some time, as your time and your experience grows, so then does the project. And when I first started this, and as I said, we looked at patients who presented to trauma units rather than major trauma units, my first question was, well, what's their outcome going to be? Does it impact their outcomes? And that's all well and good, but the question I always got was, so what? So you find out that older adults go to trauma units, they don't have great outcomes. What are you going to do with that information? we'll all stand here and point at the problem, but we want solutions, and the NHR wants to fund solutions. So that's why I changed my idea to, well, can we identify this on scene? As a service, can we better navigate patients through the system? We're not there yet, but we're getting there, and it's through that sort of growth that you find other opportunities and move through there. So start small, and if you think it's small, go smaller, and then work up from there.
Lovely. Thank you very much.
Cool. Thank you, everyone.